So our project looked at examining the association between depression and dental caries in low-income populations. So dental caries affects approximately 2.5 billion adults and 510 million children worldwide, with the greatest economic effect on low-income populations. Caries are a major public health concern due to their high prevalence, health consequences, and economic impact. Untreated disease can cause pain, illness, and impairments that reduce the quality of life. On the right here, you can see a graphic of how the social determinants of health can affect overall health. The relationship between depression and dental caries, particularly in low-income groups, is of growing interest, but the evidence remains inconsistent. There is a significant gap in research examining depression specifically in relation to caries, especially among low-income populations who are disproportionately affected by adverse social determinants of health. So overall, while caries disproportionately impact low-income populations, emerging evidence suggests higher caries rates may be associated with increasing depression severity. However, this relationship remains underexplored. The study used NHANES data amongst adults who were aged 20 or older who completed both a dental examination and depression assessment. Dental status was assessed using the DMFT index, and untreated caries were defined as one or more tooth surfaces with a condition score of 0 through 4, or the presence of untreated retained root tips. Depressive symptom severity was measured using the PHQ-9 score. The score ranged between 0 and 27, with a cutoff of 10 or more indicating major depression. Covariates included age, sex, race, ethnicity, education, income, smoking status, diabetes, and dental visit history. You can see our study population broken down by low income and non-low income on the right hand side, and you can see the breakdown of the low income group versus the non-low income group. 65% were female, 36% were non-Hispanic, Black, or Hispanic, 57% had less than a high school education compared to their non-low income group, which was at 10%, 31% had no insurance, 12% in the non-low income group didn't have insurance, 41% had not been to the dentist versus 22% in the comparison group, 15% reported having depression versus 6% in the other group, 29% were current smokers versus 13% in the other group, and 16% had diabetes compared to 11% in the other group. Descriptive statistics included means and frequencies. Group differences were assessed using chi-square, Mann-Whitney, Kruskal-Wallis tests, and the Spearman's correlation for continuous variables. Logistic regression models estimated odds ratios and 95% confidence intervals across 3 models. The 3 models, one was unadjusted, one was adjusted for sociodemographics, and the third model was fully adjusted for demographics and health behaviors. Statistical significance was set up at p is less than 0.05. In the unadjusted analysis, both depression and low income were associated with higher odds of dental caries, 1.29 and 1.27 respectively. These associations persisted after this in the second model that was adjusted for demographic and socioeconomic factors. So depression 1.2, low income 1.4 or 1.14. After further adjustment for obesity, smoking, diabetes, and dental visits, in the third model, the association between depression and caries was attenuated and no longer statistically significant. Low income remained significantly associated with increased caries risk across all models. No significant interaction was observed between depression and low income, indicating that depression did not modify the effect of income on caries risk. So in summary, low income was a consistent, independent predictor of dental caries, while the association with depression was explained by health behaviors and related factors. This is our results put into a forest plot. The ones that are in orange are statistically significant. Model 1 was the model that was unadjusted. Model 2 was the one that was adjusted only for socioeconomic and demographic factors, and Model 3, as you can see, was adjusted for fully adjusted, including health behaviors and health status. Both depression and low income were initially associated with higher rates of untreated dental caries. However, after adjustment for demographic, socioeconomic, and health-related factors, only low income remained a statistically significant predictor. These findings suggest that income level plays a stronger and more direct role in caries risk than depression once co-occurring health behaviors and conditions are considered. Low-income individuals were more likely to exhibit risk factors for oral disease, including lower educational attainment, limited dental insurance coverage, higher prevalence of smoking and diabetes, and fewer preventative dental visits, highlighting the role of structural barriers to care. In contrast, the association between depression and caries was weakened after adjustment, indicating that depression may influence oral health indirectly through related behaviors rather than as an independent risk factor. No significant interaction was observed between depression and low income, suggesting that depression does not modify the effect of income on caries. In summary, socioeconomic factors, particularly low income, are more consistent determinants of untreated dental caries than depression, underscoring the importance of addressing structural inequalities to improve oral health outcomes. Some of the limitations of the study include that it was a cross-sectional design, which limits the ability to draw causal inference. Depression was assessed via the self-reported PHQ-9 screening rather than a clinical diagnosis. Income was measured at a single point in time, which may not capture the full picture of socioeconomic disadvantage, and findings are generalizable to only non-institutionalized U.S. population. Thank you.